This was about 3 or 4 years ago then we started to look into doing the paired donation and the incompatible programs. So to talk about incompatible programs, we should first talk a little bit about what compatibility is, right? So anytime there's a donor or recipient pair, they have to first be blood group compatible for it to be a compatible transplant. If they're a blood group compatible, they have to be a tissue compatible, or histocompatible is a better way of saying it. And what histocompatibility is that you take the donor cells, which represents the donor immune, like donor kidney, and you take the recipient blood, which represents the recipient immune system, if you will, where the blood may house any antibodies that the recipient may have. And you put the two together in a petri dish and you walk away and you come back 4 hours later and you look at the cells. If the cells look alive and intact, that's great. That's a negative cross-match. Negative is good. But you come back 4 hours later and the cells are dead, that means there's something in the recipient blood that's destroying the donor cells. And that's a positive cross-match, and positive is bad here. So positive cross-match precludes transplantation, for a compatible transplantation is what I should say. So we had those technologies for doing cross-match here. But then if you want to actually do an incompatible transplant from the positive cross-match, what you then have to have in place is a way to measure how positive is that cross-match, and how likely are you going to make it negative, and how are you going to monitor and follow those patients. That took a few years to get that science down. It's been done at other centers, but we had to define those for our own self, in our own lab, in our own hand. The other portion of this is the ABO incompatible. The reason a blood group person has to be compatible with their donor is, let's take an example. If somebody is a recipient who's a blood group O, it's a fairly common blood group. The O blood group recipient has naturally occurring anti-A or anti-B antibodies in them. If you have a donor that's either a blood group A or B and you put that kidney into this O recipient, the antibodies in this O recipient are going to destroy that kidney, just like they would destroy the blood cells. So we know how to do the matching. We've done that for a while. But if they're incompatible, that's the positive cross-match equivalent for the blood group. If they're incompatible, then you have to have a way to measure how incompatible are they. And if you're going to do interventions to them, how do you follow that? Because without having that, you can't have ABO incompatible transplants. So for that, we had to import that technology into our center. We had to figure out how it works in our hands, and that we could reproduce it over and over again, that if the test was done today or a week from now or 10 days from now, it came back exactly the same way. And then we had to come up with a protocol that we could follow. So all of this was happening. We were working on the HLA end, we were working on the ABO end, and we were building our database, putting patients in. And once we had everything ready, it's sort of like the perfect storm. But in this case, the perfect storm is a good thing.